We have started the second session. Next speaker, Professor Mark Schweitzer, for the title painted sinus tarsi and impingement.
Okay. So the title of this is sinus tarsi and impingement, but probably a better title is cryptic hindfoot pain. And we'll talk about cryptic hindfoot pain now. So a lot of cryptic hindfoot pain is secondary to denervation. And this denervation could be motor or sensory. It has an insidious onset. So often a person doesn't know when it started, which is why it presents with cryptic foot pain. Now, cryptic pain is usually defined as the person has to see 3 doctors before they get a diagnosis. So Dr. 1 and Dr. 2 don't make the diagnosis. It's not till you get to Dr. 3. Now on imaging, if it's motor denervation, we can see it. So early motor denervation shows you edema in muscles, and late motor denervation shows you fatty replacement of muscle. Sensory denervation you can't see. I was once an expert witness in a case, and the lawyer was giving me a hard time. And one of the questions the lawyer said to me is, Dr. Schweitzer, you can't see pain now, can you? You can't see if this patient had any pain or not. And the answer is, of course, we can't see that. So when we see motor denervation, we can see it. But sensory denervation, you can't see. And most disorders that cause cryptic pain have more sensory than motor. And there is an overlap, and we're going to get to this a little bit shortly. So let's start out with the first case of sensory denervation, which is sinus tarsi syndrome. So whatever anyone tells you this is, what it is insidious pain on the lateral aspect of the foot. Now the sinus tarsi is shaped like what we call in English a cornucopia, or like a tuba. Like a tuba has kind of opens out like that. That's what the sinus tarsi is shaped like. So the barrel of the tuba is lateral. So typically the pain presents laterally. We'll go through what it contains momentarily, but it's mostly fat. And what you'll see on imaging is replacement of the fat on a T1 weighted image. Sometimes edema, but not always, on a fluid weighted image, and characteristically narrow edema around it. And we spoke earlier that narrow edema is a marker of pain, and this is no different. So when that lawyer asks you, Dr. Schweitzer, can you see pain? Maybe the answer might be if they have narrow edema. I can see that. So here's another example, coronal images, lateral, remember the lateral aspect of the sinus tarsi is wider, replacement of the fat with edema. Axial images, replacement of fat, less edema, but less edema doesn't really mean anything. They still might have sinus tarsi syndrome. So as we said before, it mostly contains fat. There are several ligaments within it. They're listed on the slide. You don't need to know. We'll talk about what the ligament problems are and what the non-ligament problems are on a second. This is suffice it to say there are ligaments in it. And there's a rare type of ankle dislocation called a swivel dislocation. Have any of you ever seen a swivel dislocation? I've been doing this for 40 years. I've seen it twice. So a swivel dislocation is you have your talus and you have your calcaneus. And the calcaneus swivels like that. So it goes 90 degrees and the ligaments tear because you're rotating them. So usually when the ligaments tear, the calcaneus is moving with respect to the talus. But the most common cause is the subtalar joint becomes distended. And here's the subtalar joint. Here's the anterior recess. And as this anterior recess distends, it starts pushing on the sinus tarsi. And tomorrow we're going to speak about tendons. But one key concept about tendons is synovitis is a negative prognostic indicator. When you have synovitis, you get cytokine release, you get metalloproteinase release, and that breaks down collagen. So as you get synovitis of the subtalar joint, you break down the collagen of the ligament. So the ligaments can be injured traumatically, or they can be injured secondarily from subtalar joint effusions. And those effusions could be from osteoarthritis, from rheumatoid arthritis, from gout, and we're going to speak shortly about the posterior tibial bone. So here's a patient who had rheumatoid arthritis, releases cytokines, they break down the collagen in the ligaments of the sinus tarsi, and you get an abnormal sinus tarsi from edema. So as I've said already, you lose fat, you get edema, and you get adjacent marrow edema. So losing fat, sometimes the edema is subtle, loss of fat with edema, all three points. So there are associations with sinus tarsi syndrome, and there's differential diagnosis of sinus tarsi syndrome. So let's go back. I come in with cryptic foot pain. What you should think about is it a nerve disorder? And the nerve disorders include sinus tarsi syndrome, tarsal tunnel syndrome, plantar nerve entrapment. So first thing, is it a nerve disorder? Those are the three things I think. Do I have an acute injury? If I have an acute injury, do I have a bone bruise? We'll talk about that tomorrow with ligament injuries. Or do I have an occult fracture? We'll talk about that tomorrow, also with ligament injuries. So, this is my thinking. I come in, there's cryptic foot pain. Is it on the lateral aspect of the ankle? Yes. So these are the things I think of. Is it a nerve entrapment? Is it a bone bruise? Or is it a occult fracture? Now, once I decide it's a nerve entrapment, then I need to say, is there a coalition? Is there something wrong with the subtalar joint? Particularly bodies? Is there a ganglion? Because the most common location for ganglions is the sinus tarsi. Or is it secondary to PTT insufficiency? That's kind of my diagnostic pathway before I look at an image. So here's a patient, comes in with sinus tarsi syndrome. On imaging, we see a ganglion medially pressing on the tibial nerve. Can you see the edematous tibial nerve? And can you see the subtle denervation from the medial plantar branch of the edematous tibial nerve? So cryptic foot pain, decided it was neurologic. One of the more common causes of neurologic is a ganglion, and there is this overlap between the different types of neurologic compression. Now, when you're imaging the nerves, remember, Dr. Schweitzer, you can't image pain, can you? You don't know if my client has pain. We'll talk about that 30 seconds. But we can image, as I said before, motor dysfunction. And motor dysfunction early on has edema, later on gets small and gets fatter. So if you had a choice and you had motor neuropathy, would you rather have your muscles be smaller or fatter? Who votes for smaller? 1, 2, 3. Who votes for fatter? 1. A few. So small muscles can get bigger, right? You don't think of Arnold Schwarzenegger. Fatty muscles are fatty forever. So once you have fat in there, it's irreversible. So when you're looking at imaging, the more fat, the less edema, the less reversible. The more edema, the more reversible. Now, can we see pain? Well, we can see if we don't have muscle dysfunction, but the nerve is abnormal. It loses fat around it. It becomes edematous. It has altered diffusion. All MR neurographic findings, you can see pain. So remember, comes in, has pain. Is it neurologic or is it traumatic? Well, here's a case of both. So they have an old sustentacular and tailite fracture. Can you see my arrow where the fracture was? And again, abnormal tibial nerve. The nerve looks abnormal. I don't see any motor change. But the nerve looks big and edematous. So you can't see that. Medial plantar nerve scarring, loss of fat around it. So loss of fat, edematous nerve, or large nerve. Now the most common motor denervations are the medial and lateral plantar nerves. And they are really common. So I would say of 200 feet MRI, one of those 200 will have medial and lateral plantar nerve. So half of a percent, which in our world is pretty high, right? Because that's more than just the biceps tendon tears or the elbow. So here's a T2 weighted image, and we can see edema and the adductor digiti minimi, medial plantar nerve denervation. Reversible or not? Reversible, because they have edema. That's what you want. Another example, edema. Can you see the edema? Because you want it to be soft, because that's reversible. You don't want it to be this, lateral plantar nerve, completely fatty in place. You make a diagnosis, it's easy, it makes a beautiful slide, but there's nothing that you can do for the patient. Edema, no fats, edema, medial plantar nerve. Complete fats, irreversible, medial plantar nerve. Okay, so first cause of cryptic foot pain, neurologic. Think, is it the nerve or is it trauma? If it's trauma, is it a bone bruise or a fracture? And although you make the differentiation between medial and lateral, it's imprecise. So don't be surprised if someone comes in with medial pain with a lateral. Now, I'll give you a little pearl. Posterior tibial tendon tears are medial, right? The most common symptom is lateral pain with posterior tibial tendon tears because they present late and they start tilting the foot lateral. So this anatomic distinction that we're taught in medical school doesn't work for many real patients. Now let's speak about impingement. So we talked about differentiating impingement from frozen shoulder or adhesive capsulitis. Frozen shoulder is global. Impingement is I raise up like this. So impingement is position, a position, dependent motion limiting pain. And we can define impingement, we talked about this morning, by either the vector or the location. In the angle, we lose location only. We don't use vectors. Other parts of the body, we use vectors. Shoulder and ankle, we use only low tension. And then we say, is it soft tissue? Is it osseous? Or is it mixed? So I'll show you a bunch of examples. And we talked about gender differences, right? Distal biceps tendon tears, males, right? Proximal biceps tendon tears, females. No gender differences. Impingement has no biases. It affects everyone. So here on the T1 weighted image, we see replacement of fat, and we see ill-defined edema on the T2 weighted. So this would be posterior, and it is soft tissue. So this is posterior soft tissue impingement, and the thing you would think about would be rheumatoid arthritis, because subtalar joint, ocular joint for rheumatoid arthritis, and inflammation here typically comes from the subtalar. So in the ankle, or hind foot, we have posterior impingement, anterior impingement, and anterior lateral impingement. Those are the three common locations. Now, you can have any abnormal morphology cause impingement. So this is an interesting case. So this patient came in with posterior impingement. Clinical diagnosis of posterior impingement. The talus is really, really abnormal, right? So this is AVN of the talus. Collapse. And a big piece of bone is going posterior. Can you see that? So when they go to plantar flex, they're banging. So this would be posterior osseous impingement. That would be the category. And it's some collapse from avascular necrosis on the talus. So let's use posterior impingement as a prototype. We showed you anterior, we showed you soft tissue posterior impingement. Now the rest of it is going to be osseous. And the osseous causes of posterior impingement, most of them, but not all, have to do with the os trigonum. So let's talk about the os trigonum for a second. The os trigonum, the accessory navicular, and the bipartite patella have one thing in common between the three of them. You're not born with it. The theory is when babies start to first walk, when they toddle, do you say toddle in Arabic? Toddle like in English or is it in Arabic?
Yeah. Yes.
You say toddle. Yeah. They fall, right? Right? You don't want them to fall. You get upset when they fall, and they cry when they fall, and the mother cries when they fall, but they fall. And when they fall, they fracture their patella, or they fracture their talus, or they fracture their navicular. And that's how you get accessory naviculars, bipartite patellas, and os trigonum. So it's a disgusting piece of research, but they did research on aborted fetuses. They looked at aborted fetuses, and no aborted fetus had a bipartite patella. And from that they infer that you're not born. So what happens is you develop an os trigonum, and it really is a non-united fracture. That's what you have to think about. And if it's a non-united fracture, there's fibrous tissue between it and the native bone. So the os is here, the talus is here, there's fibrous tissue between them. And there's motion, but very little motion. It acts as if it was one bone, like a fibrous non-unit. And eventually you get micromotion, and then that synchondrosis goes away. And then you get os trigonum. So let's talk about it. So here's your os trigonum, here's your native talus. And normally there should be kind of dark gray tissue between the two. This is abnormal. So we'll get back to this case because it's kind of... So here's your os trigonum, here's your native talus. Do you see how there's kind of light white tissue between the two? And do you see the edema on both sides of this? You see that the os trigonum is now displaced. So let's go through So those are end stage. So here is early osteogonum syndrome. The os, there's gray signal, and there's only a tiny bit of marrow edema here and here. Can you see that tiny bit of marrow edema? So the first stage is a little bit of marrow edema. You see the marrow edema? Yes? And the gray signal? Marrow edema, gray signal. That's early. That's abnormal, but early abnormal. Now, a lot of marrow edema, right? Marrow completely replaced on T1, but still gray signal. A lot of marrow edema. Now the signal is becoming brighter between the two. See it? Now a lot of marrow edema. You see the fluid signal? Now what's happening above this? Can you see that recess there? So now the os is moving. And as it moves, it starts blocking flow of synovial fluid. And most of the time that's in the flexor hallucis longus tendency. And now what happens? It blocks the flexor hallucis longus. So let's talk about the flexor hallucis longus for a minute. Do you know a Baker's cyst in the knee? So to get a Baker's cyst, you need three things. You need an effusion, it needs to be under pressure, and it needs to be repetitive. And that's what gives you a Baker's cyst. The flexor hallucis tendency is the equivalent of the Baker's cyst in the ankle. So you have an ankle effusion, it's under pressure, and it's repetitive, and you get fluid in your flexor hallucis longus. You have those three things. Now you have an osteogonum. And the osteogonum has moved because that fibrous tissue has broken down. And now it blocks it like a dam. And you see fluid here and fluid down there and no fluid in between. So early osteogonum syndrome, marrow edema, gray signal. Then more marrow edema, gray signal. Then less marrow edema, fluid, then motion. So that's posterior impingement, mostly osseous, and most of the osseous, with this one exception, You see osteophytes back here? Yes? And here? Very hard to see on that one. That's the one exception. But 98% of it is osteogonum. Okay, now the next type of impingement we're going to talk about is anterior lateral impingement. Anterior lateral impingement is usually soft tissue. In fact, it's almost always soft. So posterior impingement is almost always osseous. Anterior lateral impingement is almost always soft tissue. Now it happens because ligaments heal badly. We'll talk about this tomorrow. But as a preview, when ligaments heal, so I tear a ligament, it heals from the outside in. Heals from your skin towards the center of your body. 99% of the time, that's how ligaments heal. The 1% of the time, they heal from the inside out, and that gives you anterior lateral ankle joint impingement. So the ligament heals, it's torn, it heals, and the scar is on the inner aspect rather than the scar being on the outer. So here is the anterior talofibular ligament, obviously abnormal. On a T2-weighted image, this is the reconstructed ligament. But can you see the inner aspect is convex? Can you see that? And the outer aspect is pretty straight. The reverse is almost always true 99% of the time. The inner aspect is straight and the outer aspect is convex. So when the inner aspect is convex, that's anterior lateral ankle joint impingement. Now you may think it's 1%. Why the hell are we talking about 1%? 15% of you will tear your lateral ligaments this year. 15% of the population tears the lateral ligament every year. Okay? So every 6 years, everyone tears the lateral ligament. So if you're 36 years old, you've torn it 6 times. So it may be 1% of ankle sprains, but it's a hell of a lot. So don't be surprised to call this diagnosis because, and I train fellows, don't ever call a lateral ligament normal. No one ever has a normal ligament because if they're a 30-year-old and you've seen them, they've torn their ligament 5 times. So there's almost no such thing as a normal ligament. You'll never see it. We'll talk about that tomorrow. So here are two T2 weighted images. Here's your anterior talofibular ligament. You see how the outside is straight and the inside is convex? Yes? And kind of like a ball here, really? Anterior lateral ankle joint impingement. Another case, outer aspect is straight, inner aspect is convex. Okay, so posterior impingement, typically osseous, typically part of the osteogonal syndrome. Anterior lateral, and that's the most common impingement. The second most common impingement is anterior lateral, typically soft tissue, as a response to ankle sprains. The third most common form of impingement is anterior impingement. Now, anterior impingement can be osseous or soft tissue, but usually it's mixed. And it's a type of osteoarthritis. In every joint, when you have osteoarthritis, the osteophytes tend to occur in one more common area, one area more frequent. So if I have shoulder osteoarthritis, my osteophytes typically the inferior aspect of the humerus, right? That's where the big osteophytes are. If I have hip osteoarthritis, the osteophytes are typically on the medial inferior aspect of the femoral head. If I have DIP osteoarthritis, the osteophytes are typically dorsal. And I never understood this, why the fifth digit more than any other digit. But in the ankle, the osteophytes are classically anterior. So if you're reading out with a resident and a resident calls osteoarthritis in the ankle, and you disagree with them, the question to ask, do you see bigger osteophytes anteriorly or posteriorly? And chances are the resident will say posteriorly. And you should say, aha! That's why you're wrong, because ankle osteophytes are always bigger anteriorly. And because they're bigger anteriorly, they cause anterior impingement. And the reason why it's mixed is they cause a synovitis there as well, so you get a combination of osteophytes and synovitis. So here is a T2 weighted image, and we see, you can see this osteophyte, right, off the anterior aspect of the talus. And we'll show you the synovitis in a second, but this would be anterior osseous impingement. This patient, yeah, this is so do you see osteophytes here? Honestly. The senior, radiologist, very good. Anyone else? Less senior senior. Who's honest? Okay, you see him, okay. Here's a CT. Has an OCD with a cyst underneath it. Has big osteophytes. So let's go back. I think, aren't they harder to see on the MR? Do you agree with me there?
No, I think I see it.
That's why you're an excellent radiologist. So this is anterior osseous impingement. And just the point is to see what the osteophytes look like on MR versus CT. This is anterior osseous impingement. You see the osteophyte here? They don't have to be big because a little osteophyte here can cause difficulty in dorsiflexion. It doesn't take much to cause difficulty in dorsiflexion. Bigger osteophytes here, anterior osseous impingement. Big osteophytes here with synovitis, mixed anterior osseous impingement. So impingement is when you have pain in one direction. Limiting pain, motion limiting pain. And you can describe it by either the direction or the anatomic location. And in the foot, we use the anatomic location. And then you say whether it's osseous or soft tissue. And we said posterior is most common. Posterior is usually osseous, usually related to these stages of instability of the osteotrigotum. And then we said anterior is also anterior lateral is second most common, and it's typically soft tissue from an abnormal healing of an anterior lateral ligament injury. And then we talked about anterior impingement, which is typically mixed osseous and soft. The last type of impingement we're going to speak about is impingement related to posterior tibial tendon. So when you examine a person, again, I always think a radiologist should know more about clinical medicine and orthopedics. You should know more about physics than a body imagery. So when you go in and you examine a person who has posterior tibial tendon tears, you will see two things. You're supposed to look at them from the back. They have the gown on. You're looking at them from the back. And you have a thing called the too many toes sign. Anyone ever hear of the too many toes sign? So when you're looking at it, I'm sorry?
Abduction deformity, cleavers.
So the more active, not the experts. So the
Subfilar arthropathy.
so typically when I see someone, I'll see their big toe or the fifth toe, right? When you have PTT insufficiency, your peroneus longus is here, peroneus brevis is here, your posterior tibial tendon is here, and the two are like strings of a puppet, keeping the puppet in balance. So here's your peroneus brevis, and here is your PTT. If the PTT fails, as Mohammed said, the forefoot shifts laterally because you have the string of the peroneus brevis, and there's no string here. And then you get what's called the too many toes sign. Then not only do you see the fifth toe, but you see the fourth and fifth, or maybe the third, fourth, and fifth toe. And then your heel goes into balance. And you'll see them, and the toes will go out, and the heel will be in balance. You see the same thing on MR, and that's why I want to finish this lecture with this, because it goes back to sinus tarsi surgery. So your heel is going to go out laterally. And we said the sinus tarsi is bigger lateral than it is medial, right? It's shaped like a tuba. How do you say tuba in Arabic? You know, the instruments? Tuba? Do you know what I'm talking about? It's like you blow and it gives you a deep So it's shaped like this.
Cone-like.
Cone, yes. Oh, good. Thank you. And so the calcaneus is going to go like this, and it's going to smush the cone. Right? Because here's my cone, and my calcaneus goes up, and it smushes the cone. And that cone is my sinus tarsi. So that's why patients with PTT tears may present with sinus tarsi syndrome. Even though it's a medial tendon, they're now presenting with lateral pain because the nerve to the sinus tarsi is. And then the fibula starts banging against the calcaneus, and it pushes the peroneal tendons out. And a patient with PTT tear may present with peroneal dislocations. That's the first clinical sign. And then eventually, the fibula becomes weight-bearing and starts articulating with the calcaneus. And then it's not meant to articulate with the calcaneus and it fractures. So let me show you all. So here's early findings. You see the edema and the sinus tarsi. You see the calcaneus going into balance. Yes? You see the peroneal tendons dislocated. Now you see the fibula articulated with the calcaneus and fractured. And that's all lateral impingement. So there's posterior impingement, there's anterior impingement, there's anterior medial impingement, And then there's lateral impingement. And lateral impingement circles back to how we started this sinus tarsi syndrome from cryptic foot pain. So the foot is a really complicated organ, and you may get pain on one side that comes from the other side. So let's now reiterate before we go through the last slide. Cryptic foot pain is someone who takes 3 doctors to make the diagnosis. To be strongly considered as someone who has cryptic foot pain is denervation disorder. Denervation disorders can be motor or sensory. Motor is easier because it can show you edema in the muscle early, which is what you want because that's reversible. And fatty and small muscles length. And then the category of nerve disorders of the foot includes tarsal tunnel syndrome, sinus tarsi syndrome, medial and lateral plantar nerve impingement syndrome. Sensory neuropathies we can see when you have loss of fat around that nerve. I showed you that encased tibial nerve, and a vocally enlarged or edematous nerve. So yes, you can see pain. The associations with sinus tarsi syndrome, I'll just stress 2 of the most important ones. Ganglia, the most common location in the ankle for ganglia is the sinus tarsi. And posterior tibial insufficiency. A posterior tibial muscle and tendon that's not working normally. And what you see on MR for sinus tarsi is replacement of fat, edema, varying degrees of severity, and sometimes adjacent muscle edema. Now, other causes of sinus tarsi syndrome include abnormalities of that anterior recess of the subtalar joint, whether it be osteoarthritis, gout, or rheumatoid, causing synovitis and breakdown of the collagen from that synovitis. Or mechanical breakdown of that collagen from an injury or from chronic stress from PTT infection. So that's cryptic foot pain, denervation, sinus tarsi syndrome, because they're all kind of related to each other. And then we have impingement. And impingement is related because it also is cryptic foot pain. It also is large impingement. So we have posterior, which is predominantly osseous, variations of the ostrigonum syndrome, where you get narrow edema, then breakdown of the synchondrosis, and then blockage of the FHL10 sheath. Anterior impingement, which is osseous and sometimes some synovitis. Anterior medial, which is ligament scarring the wrong way. We'll talk about how ligaments scar tomorrow. It is interesting and important. And then lateral impingement, which is secondary to PTT insufficiency, and early on presents with sinus tarsi, and later on presents with sublux perineal tendons, a weight-bearing fibula, and then eventually a fracture to that weight-bearing. Then the last thing I'm going to cover is other impingements. And just for the sake of completeness, so you're aware of them, just like there's anterior lateral impingement from anterior talofibular ligament injuries, there's anterior medial impingement from deltoid ligament injuries. There's posterior syndesmotic impingement, and just to make this even more confusing, the cause is an anterior syndesmotic injury. Again, where you have the symptoms may not be where it began. So you have an anterior syndesmotic injury, and now my fibula subluxes posteriorly because my anterior ligament doesn't keep it in place, and I presented posterior symptoms. You have Bassett's ligament impingement, which is the accessory anterior talofibular ligament, and is always mixed. And as I'm listening to myself speak, I realize how confusing this is. So I apologize for that. I'm happy to leave these slides here if the organizers want to distribute them. I appreciate your attention. Thank you.
Thank you, Professor Schweitzer, for
this very nice illustrative presentation. We have two questions. We have 3 or 4 minutes. I think it was a hot topic, and it's for all Dr. Farah.
Some cases, like I see pictures of
Secondary to PTT.
I tried too hard to find tears and the PTT, but I don't find it.
So the question was finding an anterior lateral impingement without seeing PTT. So the PTT impingement is lateral impingement. So anterior lateral, I wouldn't be surprised not to see PTT.
Actually, that's
Lateral impingement. So there is a fair amount of PTT tests, not a fair amount, maybe 10%, where I think they're occult on MR. You can see them on ultrasound, I think they're occult on MR. And again, if you play the probability, so what, we'll talk about this tomorrow, but what leads to PTT tears? So another orthopedic axiom is the PTT is the coronary artery of the foot. So anything that leads to coronary artery disease leads to PTT insufficiency. So if I look at the history, and they've had a cardiac cath, and they had carotid endarterectomy, or they've had a stroke, then I'll be very suspicious of the PTT, even if it looks normal. So you can get lateral impingement without PTT. I think more likely you're not seeing the PTT, and that doesn't surprise me in this percentage.
Other questions? I have a question myself. Sometimes in osteomyelitis of the ankle joint, there is involvement of the sinus fasciitis.
Yes.
And sometimes in the neuropathic joint also.
Yes.
It's a dilemma to differentiate between the osteomyelitis and the neuropathic joint, and we need to experience differentiate between more of that.
Again, I'm going to talk about that tomorrow. But the basic rule is 95% of osteomyelitis in the foot in America is from diabetes. I imagine it's similar.
Yeah.
Of the foot. And 95% of diabetics is contiguous with an ulcer. So typically, the hind foot is less common cause of ulcers unless it's in the really back of the heel. But so most subtalar abnormalities and most sinus tarsi abnormalities are statistically more neuropathic than others.
I mean, this is clinical, but from the MRI itself, sometimes it is dilemma to differentiate between the neuropathic and the osteomyelitis.
There's nothing wrong with it. Just
I think it's the presence of skin ulcer, the presence of sinus tract, and by contrast.
But doctors both can ignore.
No, there is someone named both signs. If you inject contrast in osteomyelitis, you will see like delineation of the boundary.
Also, denervating finding the muscle can denervate.
Like you mean that the denervation of the neuropathic joint, there will be abnormal signal of the muscle.
More denervating the findings with the muscles.
I promise to show a slide tomorrow.
So you're making it.
And you told